Okay, Chapter 24 concerns the musculoskeletal system, and we're going to be looking at bones, joints, and muscles primarily. Bones can be either compact or spongy. They can, not that the bones themselves are divided, but bone tissue. The same bone might have both types of tissue. Skeletal muscle is responsible for all of the voluntary movements, and there's a long list of possible movements here, which you need to learn the definitions for each of these, and I'll leave that to you. I'm not going to go over those definitions, but look at the definitions for each of those movements. Fibrous joints are joints that have that don't actually move. Synovial joints are the joints that actually move. Examples of fibrous joints would be the sutures in the cranium. And there's a nice review of all the major joints, which include their possible movements and problems associated with each in box 24-2 on pages 532 to 534 of the textbook. So starting with history of the present concern, you'd ask about recent weight gain, and that would be particularly important, say, for somebody that came in with knee pain. Sometimes knee pain can be associated just with being overweight. You might also ask about difficulty chewing and any associated tenderness or pain that would be related to the temporomandibular joint. And then if they have a complaint, of course, we're going to do cold spa on any complaint that they would have. As far as health history, you'd want to ask about any past problems with joints, muscles, or bones, any broken bones, any other problems that they've had. And also the last tetanus and polio vaccines. If they don't remember it, that's probably an indication that they're overdue. Ask about diabetes, sickle cell anemia, systemic lupus erythematosus, osteoporosis, all of those, and then the diabetes and the sickle cell and the SLE are risk factors for osteoporosis. Also menopause and hormone replacement therapy. The menopause is another risk factor. The hormone replacement therapy theoretically will help reduce that risk of osteoporosis. And then if they have any family history of rheumatoid arthritis, gout, or osteoporosis. There's a long list of things to ask about with lifestyle and health practices. You want to know what kind of activity they're doing, so you'd ask about exercise, but also work, hobbies, anything that they might be doing. Even, say, for example, say a person is a teacher, doesn't do exercise, but he does do a lot of guitar playing. Well, that fact, the guitar playing, if you do a lot of it, can be a risk factor for carpal tunnel syndrome. So sometimes things that they do that aren't necessarily their occupation can put them at risk. And then you'd also want to know about exposure to sunlight. When we were talking about skin, sunlight is bad, but here sunlight is good, in moderation anyway. And you want to know about diet. What do they eat in a typical 24-hour period? Any medications, tobacco, the usual alcohol and caffeine, posture, and what type of shoes do they wear. Do they have any difficulty with routine activities? And if they have a problem, has it interfered with work, with routine activities, with sexual activity? What was their self-image like before the problem developed, and what's it like now? Now, you can't ask this directly, but well, you can. You don't necessarily get an answer when you ask directly, but uh, you might kind of sometimes do better if you elicit it by saying something like, well, this must have really taken a toll on you, and just see what they say as a result. Stress. And then when was the last bone density screening? And then risk factors for osteoporosis. So there are a number of risk factors for osteoporosis. Some of those are modifiable and some of them are not. Some of the non-modifiable ones are being older, female, a family history, any previous fractures, ethnicity, menopause, use of glucocorticoids over time, rheumatoid arthritis, and in males, hypogonadism. And then some of the modifiable ones are alcohol, smoking, a low BMI. That's a switch. Normally, most things we say obesity, but in this case, actually, a low BMI is a risk factor. Poor nutrition, any eating disorders, but particularly if they're low in dietary calcium or vitamin D. A sedentary life and falls, frequent falls, are also risk factors. So, to begin the objective assessment, you're probably not going to have access to a goniometer in your lab, but if you had a deficiency, if you noticed a deficiency in range of motion, that would be what you would want, would be a goniometer to quantify that deficiency. It's basically just a compass, but specialized in order to measure the movement of joints. So you're going to observe for symmetry, and you're also going to grade muscle strength using a 5-point scale, and that scale is described on page 540. Now, I've had several students who are really strong, big males who exercise and have all this strength, and I'll see their write-ups, and they'll be saying that their partner had a 4+ strength for various muscle groups. And I don't think their partner actually had a 4+ muscle strength. I think they're just expecting too much. So if you're a big guy that exercises a lot, or even a lady that exercises a lot, don't necessarily think everybody is quite like you, but consider before you put 4. Now, if you truly feel they do meet the criteria for 4+, go ahead and put it, but just a word to the wise there. So, to start our assessment, we're going to observe posture. Is it erect? And then we'll observe gait, and there are a number of things to observe with gait. How is their base of support? Are they able to bear weight on both of the feet, or do they seem to be limping? How is the foot position? What does the stride look like? Does the arm swing look normal, and what is their posture while walking? Then assess the risk of falling backwards. Be very careful doing this one because you don't want to actually push the person you're assessing over and make them fall. So you want to make sure that they're protected when you do it. And you just nudge their sternum and see if they fall backwards when you do that. But be ready to catch them if they do start to fall. Then inspect and palpate the temporomandibular joint, just where the two jaws meet. But of course you're doing this from the outside. And then you're going to test the jaw range of motion against resistance and grade it on the 5-point scale. Then assess the sternoclavicular joint, and you want to observe the spinal curves. We'll look at those a little later too when we look at the hips as well, but observe the spinal curves. Then you're going to palpate the spinous processes and the paravertebral muscles along the back, and you're mainly looking for any tenderness there. Assess the range of motion of the cervical spine. Most of the time I won't give you the degrees. They are listed in your book, so I'll let you look those up. But here, 45 degrees going forward, 55 to the back, 40 laterally, and 70 by rotation. Now like I say, you probably won't be actually measuring these, although if it looks like they're not within the normal range, then you would want to measure it. Then you'll assess the range of motion of the lumbar spine, and you have them do a toe touch to start that process. And when they do the toe touch, why you want to look at the scapula, shoulders, and hips. Are they all level? And again, we observe this, those lumbar curves for looking for problems like scoliosis, kyphosis, problems like that. But maybe the problem would show up there when we ask them to bend over and touch their toes. And then we're also going to ask them to extend the lumbar spine and to do some side-to-side movement and assess that range of motion as well. Then test for back and leg pain. You have the person lie flat, and this is somebody obviously that tells you they have back or leg pain. They lie flat. And then you're going to test each leg separately. Raise the leg until the pain occurs, and then you dorsiflex the foot and see if they have more pain with that. And then repeat with the other leg, and you're going to note how far that leg can go before the pain occurs, and what happens when you do the dorsiflexion. Then I said measure foot length. That's wrong. It should be measure leg length. The legs should be within 1 centimeter, but the differences can sometimes be real, or sometimes they can be the legs are actually the same length, but due to, say, a spinal curvature or something like that, they can be apparently of different lengths. So if that is the case, like to measure the leg length, you would measure from fixed point to fixed point. But to measure an apparent difference in leg length, you would use a fixed point not on the leg, such as the umbilicus, and then measure to a fixed point on the leg, such as the malleolus, the internal or external malleolus or something like that, and measure the same point on the other leg. Next, we're going to turn to the shoulders, and we'll inspect and palpate the shoulders and arms. We'll test range of motion of the shoulder, and the shoulder has a number of different possible motions which are listed here, and you're going to test all of those. And when you're testing range of motion of these things, you do it passively. Well, you do it not passively and actively. You do it actively and also against resistance to see if their muscle strength where it is on that 5-grade scale, because if they can just do the range of motion, that's fine, but you also want to test the muscle strength. Then inspect the elbows for size, shape, deformity, redness, and swelling, and test range of motion of those elbows. Elbows flex and extend, but they can also pronate and supinate. Now that's going to be seen in the forearm, but it's that elbow joint. Then inspect and palpate the wrists, and then there's a squeeze test, which consists of just squeezing that wrist and seeing if there's pain. There should not be normally. And then palpate the anatomic snuff box. And to find that, see page 549. If the anatomic snuff box, if that can indicate, that palpation of the anatomic snuff box can indicate that the person might have had a scaphoid fracture at some point recently due to falling, say, on an outstretched arm. Then test range of motion of the wrists. They can either extend, flex, ulnar or radial deviation. Those are the possible movements. And then we're going to do several tests for carpal tunnel syndrome. Phelan's test, the two wrists are flexed at 90 degrees, and they're just pointed straight at each other. And you hold them like that for 60 seconds and ask about numbness, tingling, pain. There should not be any. Tinel test, you tap over the median nerve and ask about numbness, tingling. There shouldn't be any. And then if there is, you'd say, oh, well, what do you do when you get to feeling like this? And if they show you like a flicking or shaking motion, why then that's another sign of carpal tunnel. And then also test for thumb weakness. Test the thumb to see if there's weakness there, which can be an indication of carpal tunnel as well. Okay, fingers, assess for size, shape, symmetry, color, and then palpate them. And then finger range of motion. They should abduct, adduct, flex, extend, and then the thumb should go away from the fingers and also be able to touch the base of the small finger. Inspect symmetry and shape of hips. Test hip range of motion. Don't do this with people that have had a hip replacement though, but with people that have not. So it's kind of hip has various movements: flexion, extension, abduction, adduction, and internal and external rotation. Now the knees, a lot of times people will come in with complaints about their knees, whether it be swelling, pain, being unable to walk or climb stairs without having knee pain, that sort of thing. So after you've inspected and palpated, then you might want to do a bulge test. This is for small amounts of fluid, and the swelling, and you stroke the medial side of the knee several times with the full hand on the medial side, and then press the lateral side and look to see if there's a bulge as a result of that on the medial side. Then the ballottement test is for large amounts of fluid, and that one with the left hand, you grasp the proximal patella using the thumb and the fingers of that left hand. This is assuming you're on the right side of the body, of the patient's body. And then you push the lowered patella down using your right hand. you should not feel rebound, you should not feel crepitus. But if there is fluid in there, you'll feel rebound from like a wave of fluid. Then the range of motion of the knees consists of flexion and extension. And you may want to do, if they have knee pain, you may want to do the McMurray test as well. And with that one, the hip and the knee are flexed, they're laying flat. You put one hand on their foot and one hand under the knee, or no, on top of the knee, sorry, on top of the knee, one hand on top of the knee. Rotate the lower leg laterally, and then slowly extend that knee, observing for pain or clicking. And then you get it back up in the 90-degree position, and then you rotate it internally this time, or medially. Rotate it medially, sorry, and then repeat the process, also observing for pain or clicking. Then observe ankles and feet as the client walks. Palpate the ankles and feet. And now we're going to assess the metatarsal phalangeal joints. You're going to squeeze the foot from each side using thumb and index fingers to palpate each joint. And the illustration for that is on page 558. Then we'll do a squeeze test of the foot. There should be no pain or discomfort with that. And then we'll test the range of motion. There should be dorsiflexion, plantar flexion, inversion, eversion, abduction, adduction. So that was a long assessment, and I only included a few diagnoses here. There are many more listed in the book, and there are probably many more possible diagnoses. They're only limited by the number of conditions that people can have. Risk for fracture related to decreased bone density. We know that one of the main problems with osteoporosis is increased risk for fractures. So that could be a risk diagnosis. And then risk for trauma related to repeated movements of elbows or wrists. So that would be somebody that's at risk for carpal tunnel disease. As far as actual diagnoses, impaired physical mobility related to impaired joint movement as evidenced by decreased range of motion. Someone that does have, say, a problem with a joint, say osteoarthritis or rheumatoid arthritis, they'll probably have some impaired mobility on the joints that are affected, and so it can affect everything from walking to self-care to ability to reach their back with their hands, or it impacts, has a lot of different effects on a person that you would not necessarily think about. So that's why we ask, what effect has this had on your daily activities? Then activity intolerance related to weakness, muscle weakness as evidenced by inability to overcome resistance. That's the person that's able to do the range of motion, but when you put resistance, they're not able to overcome your resistance, so you grade them, say, at a grade 3 muscle strength. Then as far as collaborative problems and referrals, risk of complications for osteoporosis, compartment syndrome, we haven't talked about that. But what happens is in compartment syndrome is that due to swelling, the nerve and in artery and vein that are feeding apart become compressed, and so you have decreased movement, decreased sensation, swelling, pain, and then numbness as well. So that is the point when we have somebody with a cast with traction after a fracture, any kind of orthopedic injury, we're going to do what we call circulation, motion, and sensation tests, where probably about every time you do vital signs, you'll be testing that extremity. Like, say, if it's an arm, you'll be testing the fingers, or if it's a leg or femur, the foot, ankle, something like that, we'll be testing the toes. And so you ask the patient to move those toes, and if they don't, if they can't, why then that's kind of alarming. Of course, you would want to check what they were able to do before too. If they haven't been able since the beginning of the injury, then it's not so alarming. But what's alarming is when new problems develop, because that indicates that the person might be getting the compartment syndrome. So you ask them to move, you test the sensation of each finger or toe, look at the color, you can do capillary refill as well, those kind of tests. And if you think that the patient is developing compartment syndrome, why, you want to notify the doctor right away, but there's a few other things you can do as well. You can raise that extremity, get some pillows and put the extremity up on pillows, and maybe get some ice as well. But you're not going to put the ice on the fingers or toes. You're going to put the ice on the area where you think the swelling is occurring. So the ice would be up higher. Okay, well, that is all for this lecture. Thank you, and we'll see you at the next one.